Thank you. The private sector health dialogue and the launching of the 10 billion naira private sector healthcare intervention fund. Tomorrow, the 12th of August 2021, at the International Conference Center here, by the special grace of God Almighty, we will be gathering like this to receive Nigeria, to receive Nigerians, to receive the private sector of our economy, to a first of its kind private sector health dialogue. As you know, a lot of talking is ongoing and it must continue. The greatest thing men have done on earth is talking. Why must we keep talking? Because it is in the words we declare that power comes, that possibility comes, that result comes. As we know, even the word itself was created by the word of mouth. There's power in the word. Tomorrow we will experiment and demonstrate the power in the spoken word. Under one roof, the entire private sector Nigerian representatives will come together, led by the AGPMPN. We want to show leadership. We want to show direction. We want to show a path out of the woods for the Nigerian state. As we know, the private sector of this economy is the highest provider of healthcare, the Association of Private Doctors. We are the highest providers. It is not in doubt. Nigerians know it. Our governments confess it. But in confessing it, they take us back to this usual slogan of the PDP party. They tell you PDP power, PDP power, power to the people. That is a true confession of reality, because the people are the strongest element in any society. There is no power as powerful as the people power. But ironically, in our own country, a few leaders have usurped the power of the people, and so they make jest of us, remind us of what belongs to us, and yet they confiscate that same power and reduce us to mere beggars and watchers and commentators and lamentators. But evil will not go too far. As I say always, that lies may be fast in traveling, but the gentle, slow steps of truth will always overtake lies before it goes too far. As long as men are watching, sensitive, and responsive, you have to be responsive. That is what we'll be doing tomorrow. We want to articulate a private sector perspective to the healthcare delivery system of Nigeria. We want to raise a voice, because if we are the largest providers and the highest consumers, where is our voice? Where is our influence? Where is our presence? Where is our impact? Nothing will change except there's a break in concordance. We want to break concordance and begin to ask questions and begin to say no and begin to show leadership. We will deposit on the desk of our government at the end of the day a communique clearly defining the thinking and the calculations of the private sector of how better our healthcare system can be managed. Because indeed, we have gone too old after 100 years, gone too old after taking over the country's health system. Like I told the Honorable Senator, the distinguished Senator, that the best hospitals in this country at primary level, secondary care level, and tertiary care level, they are in the private sector. We need to declare this, and we need to sound it wherever we go. We need to establish the fact that we are in charge indeed. By the end of that dialogue of tomorrow, We desire also to raise funds as part of corporate social responsibility to the poor Nigerian people. As leaders and people, professionals, completely unified to Nigerians. There is no village you go to in Nigeria today that you will travel more than 10 miles without seeing a private doctor. Some of us are in some rural areas, they don't see newspaper to read. But thank God for sound waves. They can always listen to radio and, of course, watch television. Otherwise, such colleagues of yours and mine would have been excommunicated from the real society, like prisoners. We are making such sacrifice. And because we are everywhere and we meet the people in their raw state, we understand more than anyone else the challenges of the Nigerian healthcare system. We know, for example, that our life expectancy as a people is about the lowest in West Africa, in the sub-Sahara, lower than Cotonou here, lower than Togo here. It is a calamity. And how do we reverse such an ugly trend if you keep watching and complaining? We want to begin to take decisions and take actions. We want to stand with our government, support them and partner with them to see what else can be done to improve our system. You are aware that the maternal and infant mortality rate in Nigeria is the highest, obviously in West Africa and in Africa, and we'll be competing with the very worst in the world. The question is why? In a country so endowed, so naturally enriched, so blessed, and the question is, into poor, wretched beggars. We must interrogate circumstances. So because the world is speaking a common care, we have a private sector that is sensitive, that is responsive and passionate, and indeed compassionate. We want to raise funds to inspire capacity building in our rural environment, to support the struggling poor Nigerian who can't access care. And we also know, my dear colleagues, fellow Nigerians, that our health insurance system, 16 years after, is still struggling to sit or crawl. It is an unfortunate reality. As I speak to you, Rwanda, that small Rwanda, that country that just came out of the ugly experience of almost near extermination, has gotten their acts together. And 7 years after going into health insurance, they have covered 97% of their population. And so the average Rwandan is a healthy man. Health is a feeling. If a man is sitting down and he knows that if I have headache or I have a broken bone, I don't need to think of where to get money to treat myself, that man is already healthy because the mind is stable, comfortable, without anxiety and no despondence. We need to support this same philosophy in Nigeria. No nation, no people will support a program they don't understand. The average Nigerian out there does not know what health insurance is. We want to convert our consulting rooms wherever we are to educate Nigerians on a one-on-one basis. Every consultation should be given 1 minute to tell the Nigerian what health insurance is. We will go on with flyers, billboards, media, publicity, print, and electronic. And thank God for this era of social media, where you talk to one man, you are talking to the whole world. We will deploy every arsenal of communication to support this effort, so that by 2030, as our government has promised, we'll get to that point where a medical emergency will no longer become or remain an economic or financial emergency, because the Nigerian man or woman out there, rich or poor, employed or unemployed, will have such access to hospital care that guarantees it with or without money, and only a functional health insurance that has a big umbrella, big enough to cover everybody in what is called universal health coverage, can do that. It is possible. We just have to decide, and we want to start that journey. Gentlemen and ladies, let us remain together and united in this effort and transform the landscape of our own country for the sake of posterity, reflecting history along it. The private sector has hope for the health system of Nigeria. Like I said earlier, we have men here. The last time we visited Cedar Crest, for example, I was in his office with my team as late as 10:30 p.m. This man is a constant benefactor of the healthcare industry. This man is shy, public shy. You see him, the man is uncomfortable. He doesn't want to be talked about, but we don't have a choice. We cannot have gold in our hand and we are moving as if they are rock. Each time you go to Cedar Crest, there's something new happening. There's an expansion project going on. There's an innovation taking place. There's a super specialization experiment going on. I'm aware he started as an orthopedic unit, but I am correct, and my colleagues, we must agree that at the end of the day, even the most specialized is a general practitioner. Cedar Crest has gone into everything, because that is what it should be. He has expanded his scope to offer more help to Nigerians, because initially he was truly limited. How can you be there and the patient is rolled in, perhaps obstructed labor, and he said, no, all we do is bone. Go and break your bone and come back. No. He says, whatever it is, come, we are prepared. Such a man has established Dubai in Nigeria. We are proud of him, and men like him, we were in DIF, we were in Alliance, we have been everywhere. That is why we must boast of what we have. The champions of the healthcare system of Nigeria. In the days of COVID, our government was playing games, playing hide and seek, lying to themselves. They will come to the open and say, private hospitals, you're not part of it. Don't go near. If you go near, the electricity of... A good everybody, working with everybody, fight the common front The world is a global village. A few inquiries should reveal to our businessmen and women that the health sector is the biggest and the largest sector, the richest sector of the Nigerian economy. There is none like it. Because the health sector is into a business which product is needed by everybody. The man who is sick needs the health system or needs health care. The man who is well needs health care. Everybody needs you, which means 200 million Nigerians are our customers. It's big, it's huge, it's massive, but the philosophy of it, the ideology of it, the conceptualization of it is what has perhaps eluded us, the understanding. In America, in Europe, businessmen, doctors don't own those big hospitals, but you can't run a hospital without the doctors and nurses. Businessmen will come together, pool billions of dollars and set up massive structures and extraordinary systems, partnering with their doctors. And that's what you have there. We are encouraging our businessmen to locate private doctors wherever they may be. The city of Abuja was a forest. Every city you see in the world was once a slum. You can choose one village and make it another medical tourist destination as a businessman. Healthcare is universal, and there's no distance. But there's no doubt that by the reason of the peculiarity of this conference, this hall would have been too to accommodate spending more than he is getting. And many of us are struggling to survive. But by his grace, with new orientation, new ideas, new philosophies, and a change in our mode, in our system and strategy, knowing also that the only way to get out of where you are is to do things differently. Our people must get out of this encasement. And so, the nation is weak. Infrastructure is weak. Security is poor. Many are not here because of fear. And so we are calling our federal government to continue to do the best that they have and not to politicize our security. Number one, welfare index of governance is security. Security of lives and property. And of course, as our slogan says, the health of the people, the greatest wealth of the nation is the people's health. If the people are healthy, then they are happy, they are strong, they are productive, and certainly patriotism will come from there. Why are Nigerians living? Doctors are living, nurses are living. Our own people are also living with them. You go here, from here to London, and be treated by Nigerians, because Nigerians are a blessed people. Anywhere you go, in America, I was in Jamaica, I saw them. Everywhere you go, you see Nigerians, and they are the best. This wrong orientation in Nigerians that have been sustained by bad leadership and bad infrastructure and bad economy and bad everything must be addressed. Because in every interview I've given in the last few months, I have described the medical brain drain as the next cancer that may consume this nation. Because the way we are going, as I'm talking to you now, 3 of my nurses have just resigned to join 5 that have left in the last 6 months. I have lost 2 doctors this year, one to Saudi Arabia, one to UK, and one is preparing. In fact, my gynecologist, before I left, we discussed. His wife is a nurse. His wife has been in the UK for the past 6 months. The children have moved. He is preparing to move, and he has come to me. He's due for his leave, 30 days leave. But he has said, allow me my leave, but allow me additional 2 months of leave without pay. What is happening? He is on his way out. I called my admin manager and HR. I said, please don't take for granted what is happening. This is the precursor to the letter of resignation. Take it that he is gone. And that's the way they are living. My diagnostic center lost 5 radiographers last year. 2 have left this year. From the hospital, 1 has left. They are all living. Something is going wrong. Our leaders must wake up. And we must tell them the truth. If that's the least we can do, we need to save this country. By the time they all leave, Nigerians will start dying more of common malaria than they are dying from the bullets of terrorists. Finally, my dear colleagues, in conclusion, our healthcare system is truly in their need of support. The private sector of Nigeria has shown leadership in the sector. Today, as we gather, the best primary healthcare centers in the private sector, the best secondary healthcare centers are in the private sector, the best tertiary healthcare centers in Nigeria are also located in the private sector. This is despite the lack of deliberate government support. Our dear President, distinguished legislators, Honorable Minister for Health, worthy Nigerians, give us the enabling environment and we will take our competitive index in healthcare beyond the boundaries of Nigeria and reverse medical tourism from Nigeria to Nigeria, as well as truncate the unparalleled desire doctors, healthcare workers, and Nigerian patients have to leave the country for other places. Thank you for your attention. God bless you.
Thank you very much, Mr. President. Another round of applause for him. That was a full lecture. While the president was talking, delivering his speech, someone just walked in. Please, can we be seated, please? The #1 medical doctor in Nigeria, the president of the Nigerian Medical Association, Dr. Innocent, Professor Innocent, sorry, sir. Professor Innocent Abuja, MNI. You are welcome, sir. We can do better than that for our president too. Okay. You are welcome, sir. We are very happy to have you in our midst. Distinguished delegates, at this point, I would like to invite the chairman of this occasion to just give us just brief 2 minutes remarks. Mr. Chairman, sir. Dr. Gabriel Oga.
Good afternoon once again. All protocols observed. Welcome my good friend, President of NMA, and all the other great people that are just coming. After that brilliant lecture given by the President of AGPMPN, there's nothing much to add. But I must emphasize that we must reiterate that the only way to develop a society is to develop the human beings. If you don't have any human beings, you cannot have good roads, you can't have security, you cannot have anything going on. How many people know that the greatest cost of a car, be it a BMW or a General Motors car, is the air care of the workers? The amount General Motors spend on the air care of workers is the greatest cost of the big cars you ride. That is why those societies are making it. I want to re-emphasize what the president said. People should invest in health professionals. Don't meet a doctor. Come and let's build a hospital. How much do you have? You cannot be a good and great doctor if you have a lot of money, because the time you spend specializing and learning your skill, you don't use that time to make money. Ronaldo did not build any stadium. Messi did not build any stadium. Maradona did not build any stadium. You build a stadium, you create an environment and let the professional develop his skill. What people, bankers in Nigeria who are receiving a lot of money did not build any bank. You build a bank and you call a good banker to help you run it. Businessmen, the government, should build good hospitals and pay doctors well to run it. It is the business of government, because government collects money to take care of the health care of the people. If you are in a village, even if the population of the village is 10,000, the government is supposed to tell all the villagers to go to the hospital there and pay the doctor at the end of the month. That's what Europe does. That's what UK does. That's what Canada does. That's what Australia does. You are not doing a doctor a favor. If you tell everybody in Gariki to go to these 2 hospitals there, at the end of the month, you pay the doctor. That's how you are going to have a good healthcare system. Invest in us. Investing in us is investing in the country. There's nothing much to add. Thank you for being here.
That was a very wonderful one. Can we please stand up and appreciate our Board of Trustees member, the past president of this association, the chairman of this occasion, Dr. Gabriel Oga. Distinguished delegates, ladies and gentlemen, we have arranged for us to have a walking tea break. We'll be directed from row to row to go for your tea break. At this point, one of the high points of this event is the Andemewa lecture. Andemewa was the first president of this association of blessed memory. To take this lecture in this 43rd annual general meeting, so please, before the Andemewa lecture, apologies to our guest lecturer. I want to quickly invite the #1 doctor in Nigeria to just give us a 5 minutes goodwill lecture, goodwill message, please. Let's bear with him. So it's my privilege to invite to the podium Professor Innocent Oja MNI for his goodwill message. A round of applause for Prof, please.
The chairman of the occasion, my very good friend, Dr. Gabriel Oga. Oga is a very good friend. We did our residency together in Zaria in those days, and I appreciate his presence. The president of AGPMPN, my very good friend too, Dr. Ike Odo, distinguished guests, members of the medical profession. Let me first of all apologize for coming late. I have very good reasons for coming late. The first reason is that the roads are very bad. And I'm coming from Benue. The second one was that I'm not sure if there was provision for me in Abuja to stay overnight. So I needed to organize myself to come this morning. And I'm coming right from Otuko to this place. Now I've not gone to anywhere. Again, because one, I'm a medical doctor. Two, I respect the profession, and very particularly the president, who has been in touch with me. And I give my words that I will be here. If I was not going to be here in person, somebody else would have represented me, but I consider it very, very important to be here myself so that we can see ourselves and discuss together. I appreciate the topic for this annual conference. As you all know, the COVID-19 pandemic has distorted every facet of life, including healthcare. And therefore, what we needed to have been doing normally are clearly distorted. But we cannot continue to lament. We must face it squarely. And before I start, I want to thank all of you, Nigerian doctors, for your faith, for your commitment, for your dedication to the service of Nigeria. It has not been easy, but you have confronted this frontally, despite the ravaging COVID-19 pandemic. I want to use this opportunity to thank all of you. Now, I want to say that Nigerians' health is in crisis. If I say it's on life support, it will not be an understatement. But the reality is that we have lost direction for quality healthcare in Nigeria. We recall that for the past 10, 11 days, the National Association of Resident Doctors have been on strike. Strike because the enabling environment to practice is no longer conducive. Strike because the basic requirements, and that's the salary for the service, have not been paid. Even those who died in ensuring that those who have COVID were spared. They died for others to live. Their benefits have not been paid. The residency training program is neither here or there. And as if that is not bad enough, the Medical and Data Consultants Association of Nigeria has given a 21-day ultimatum to go on strike because on the unfair treatment of Nigerian doctors. And it's as if to be a doctor is a punishment. I thought those who are doctors and who are doctors are the most intelligent and in any class at all. I didn't know that it has changed. If anybody would tell me it has changed, then I'll have to have everything. But in my class, I was certainly one of the best. And that was why I read medicine. And it was only when you are good that you read medicine. But these days, you'll find people who barely pass their school SAT with third class, determining the future for this country. I thought that is completely not correct. It is not a sin to be a doctor. I have not seen it. And if any other person has seen it, should let us know. But I thought that a Nigerian doctor is giving his best to the Nigerian people. and they need to be treated fairly. We're not saying they should be given any superlative treatment. We're saying they should be treated fairly. So we have to do something about this, and it is going to be a collective effort, not just one aspect, not just NAB, not just MD-CAN. As I talk to you, even as professors of medicine with a hard-earned fellowship, we have been excluded from being a vice chancellor, contesting for vice chancellorship in Lagos State University. This happened in University of Jos in 2011, and I went to court. I was the Director General of the Nigerian Institute of Medical Research. I did not apply to be Vice Chancellor of the University of Jos, but I went to court because my profession was being rubbished. And today we got a judgment in our favor. So we'll test all grounds. We'll test all grounds so that people will know. I mean, what is it? The envy in medicine or envy against doctors is too much. It's too much. Suddenly, I mean, you or any doctor, any Nigerian medical practitioner, now and in the future, you either had done your housemanship before you are qualified to be certified to be a doctor. And then, of course, you do NYSC. Suddenly, circulars are flying all over the place. House officers, you call doctors, are taken out of a scheme of service. What have we done wrong to Nigeria and to Nigerians and to the civil service? They need to tell us. It is a requirement to be a doctor. And to be a doctor, you must do your housemanship. So why should it be taken out of the scheme of service? Nobody has told us. We have written a series of letters. And I don't see why this is coming at the moment when our head of service is a medical doctor, it's a dental surgeon. He's gone through the housemanship before he qualified as a doctor. So why should such a thing be happening? Is it that she's placed there so that the underground, they'll just remove the carpet under her, or she's a willing tool to be used against my Nigerian doctors? It's something that we need to reflect on, because it is a very painful development. Circulars are coming from everywhere. All are directed against doctors. Is it so? We need to find out. We've been trying to use diplomacy, we've been trying to use advocacy, we've been to use negotiation, but it appears it is failing. So my colleagues, the Nigerian doctor is an endangered species at the moment. Closely to that, we're talking about private practice. We're talking about medical tourism. I tell people that if you go to India, you're not going to government hospital in India. You are going to private practice in India. That is well built, well positioned, with excellent enabling environment. The same cannot be said in Nigeria. If you are a doctor and you are practicing, you make sure that your tax goes to high heaven. Why? You are providing service. So advocated, and I'm advocating, that we need to have a health bank. A health bank, just like Bank of Agriculture, just like Bank of Industry, so that our private practitioners can then go there and get loans. They form a consortia, get loans at single-digit interest rate. This has been one of my messages since I became president of the Nigerian Medical Association. And we continue to advocate for that. We've gone to the National Assembly. We'll be presenting to Mr. President because we think that's the right thing to do. many private practitioners cannot cope with the rising cost of equipment and even buildings. So I think that we could do better if the government creates an enabling environment. And in this case, we should be able to have a health bank, whatever name you call it, but let it be established like Bank of Agriculture and Bank of Industry. Human capacity development is one of the greatest assets of any nation. And Nigerian doctors have shown unparalleled commitment to service. And we need to be supported in whatever way we request for. So we are really at a crossroads. The issue of medical tourism is at its highest. Fortunately, I must say that of all the bad things brought by COVID, there's one thing that is a positive aspect, and that means it has stopped the big men and women from going abroad to seek for medical care. Because if you go, you will come back maybe in a coffin. So you don't need to go. So we are conserving what? We are conserving foreign exchange during this period. Otherwise, people will just fly out at will and use government money. Mind you, if you're going out with your own money, because it's fundamental human right, we don't have no quarrel, but don't go out with government money. The government money should be used to improve the healthcare of our people, the facilities, the equipments, the consumables in this country. And I believe that it can be done. If it can be done, then let's frontally approach it. The issue of brain drain, is coming at a time that we honestly must be weeping as a country. I mean, what the president of AGPMPN has said is correct. Nigerians are going out on a daily basis, let me not say hourly basis, so because it seems to be exaggerated. But Nigerians are going out. Nigerian doctors, nurses are going out. And why are they going? Because the environment here is no longer conducive. We're not even talking of the issue of insecurity. But I must say, in the last 1 week, I think the military have descended heavily on many of the bandits, as we read. But the situation is such that the environment must be conducive for practice. Otherwise, Nigerians will go. Nigerians are very well trained as doctors. There's no clue about that. And all they need to go is to go out. And they get the best. But why should we allow that to happen? The government should intervene very quickly, because if we don't do that, we will be left with people that will be overworked and therefore will not give their best. We cannot go to war with army of cripples and expect to win the war. And what we need to do is to keep our people here, give them the best that they need, create an enabling environment so that we can provide the best quality service to our people. Nigerians deserve the best, and we must give them the best. So, Mr. Chairman, my friend and President, I thank you for giving me the opportunity to speak before you, and to also please, I want to plead with the President that the NMA house has started. We have started building an NMA house. And at next meeting in Benin, which will be from the 22nd to 28th of August, the progress report will be shown. It's being compiled, and we will develop new strategies for funding, and that will be unveiled during the next meeting in Benin. Having said that, I wish you all the best at this conference, and thank you, and good afternoon.
Mr. President deserves a standing ovation. Thank you very much, Mr. President, Professor Innocent Uja, MNI. That was a very Straight one. May we be seated, please. While Mr. President was delivering his goodwill message, the chairman of NMA in FCT Abuja, who is our grand host, walked in, Dr. Inema Joe. Stand up for recognition, sir. You are welcome, sir. NMA chairman, FCT. So having said that, it's my privilege this time to invite Dr. Felix Ogedegbe to please step forward. He's our guest lecturer for the day. A round of applause for Dr. Ogedegbe. Dr. Felix Ogedegbe, MBBS, FWCS, FICS, FRSM, is a consultant orthopedic surgeon and Group Medical Director of Cedar Crest Hospitals Limited, Nigeria. He is an alumnus of the School of Medicine, University of Benin, and the Orthopedic Residency Training Program of the National Orthopedic Hospital, Lagos. He had further work and training at the Center for Musculoskeletal Surgery, Charit Hospital, Berlin, Germany, and the Department of Orthopedics, Newham University Hospital, London, United Kingdom. He has also attended various professional, business, and administrative courses, home and abroad. His orthopedic experience spans over 20 years, the first half of which was spent as an orthopedic surgeon in the Nigerian Army, retiring voluntarily as a major in 2007. He has spent the last 14 years working with colleagues to develop Cedar Crest Hospitals, one of the Nigeria's foremost private multi-specialty hospitals with centers in Lagos, Gudu, Abuja, Gwarinpa, Abuja, Kainji, and Jeva. A round of applause for him, please. He works as a medical administrator and combines this with an active surgical practice, mainly in orthopedic trauma and arthroplasty. He is active in medical education and currently works with colleagues to run a residency training program in Cedar Crest, Abuja, the only private hospital accredited for orthopedic training in Nigeria. Dr. Ogedegbe is a fellow of the West African College of Surgeons, the International College of Surgeons, and the Royal Society of Medicine. He is also an active member of several local and international professional bodies, including membership of Nigerian Medical Association, Nigerian Orthopedic Association, Arthroplasty Society of Nigeria, the Guild of Medical Directors, American Academy of Orthopedic Surgeons, and the J. Robert Gladden Orthopedic Society, USA, among others. Dr. Ogedegbe also serves as director of Cedar Crest Polio Center, a not-for-profit organization. The president of Arthroplasty Society of Nigeria. Is the chairman, National Emergency Medical Treatment Committee. Is the member of the FCT Ministerial Expert Advisory Committee on COVID-19, and a member board of directors, Federal Teaching Hospital, Gombe. He is committed to ensuring the availability of highly specialized medical care facilities in Nigeria to our people and our neighbors. He's a committed Christian and is married to Dr. Evelyn Ogedegbe. They have 3 children, Ofure, Esore, and Izebokai. A round of applause again for Dr. Ogedegbe. You are welcome, sir.
The chairman of the occasion, Dr. Gabriel Oga, president of the AGPMPN, president of the Nigerian Medical Association, past presidents, executives, distinguished doctors, ladies and gentlemen. It's my pleasure to be here and invited to give this talk. I do count it as an extreme privilege to be able to address you this afternoon. I've been asked to lead a discussion on the private doctor's experience. So I guess my talk is up. So it's post-COVID-19 medical practice, a private doctor's experience. And I just want to share with us in the house what our own experience in our practice has been. Just looking at the high point and not to bother us with a lot of details. So that's by way of introduction. I chair the Cedar Crest Hospitals group, and I work with a lot of colleagues who are all members of the AGPMPN and the NMA in trying to ensure that we are playing our own part to make sure that healthcare is available locally. Next slide, please. So we're all familiar with this issue of COVID-19, which came around the end of 2019, and so it was so named, and it stayed with us till date. So when I first saw the topic, talking of the post-COVID-19 medical practice, I thought it should rather say intra-COVID-19 medical practice. We're still, sorry? Yes, okay. Right, so we're still right in the middle of the COVID situation. We do know that it's a significant public health problems. It's affected all of us, affected the way we've practiced medicine. And it's been attended with a significant morbidity and mortality among healthcare workers. We hear of doctors who have died. I think we've recognized them this morning earlier. We hear of people who looked after patients. Some of the patients survived, some succumbed, but doctors and nurses and all the other people who are very dear to us, some of them have actually been lost. And so the COVID-19 situation has come to challenge the status quo, has come to change the way we do things. It's almost like the 911 event changed traveling in America. Once the COVID-19 started, I actually went to start digging up stories about the 1918 pandemic, the so-called Spanish flu. And a lot of similarities between 1918 and what came about 101 years after in 2019. Of course, the latest in the block of things going on will be the vaccination, which in this country, people have had very different ways to react to vaccinations and the ideas around vaccination. I think we still have very low figures in terms of about 2 million of 200 million being vaccinated, which means that we just have about 100% coverage, and that has issues. But here we are just to rub minds about continuing medical practice in spite of this COVID-19 era. So in the post-COVID-19 era, what can we do? So we've looked at the impact on our own group, and our group, just as we said, we've got a hospital in Abuja, where the flagship hospital is, one in Lagos. We run 2 community hospitals in Kainji and Jeba, and then we also started a Gwarimpa Center and a few other locations where we do outreach services. And we've also had a very way of looking at the impact on our major areas of clinical practice. Orthopedics is what we started with, but we've gone into other areas of surgery, including general surgery and neurosurgery, medicine, including the fact that we just opened a cath lab for cardiac catheterization, pediatrics, obstetrics and gynecology, emergency medicine, which I'm beginning to find extremely interesting, and intensive care. And how it affects, how the COVID situation has affected the kind of services we provide, in outpatient service, the inpatient service, surgical operations, that has had a huge impact, radiology service, laboratory service, COVID-19 treatment, and testing. So I'm sure in our practices, we had various ways of responding to the lockdown, and that was major. April 2020, the whole place was locked down and there was virtually no practice. And then, of course, some of us, I belong to the FCT ministerial expert advisory committee, and we had to look at ways to safeguard the FCT, just in working with the FCT, the health authorities here. And we're meeting virtually every day just to make sure that we get things under wrap. And then thereafter, there was a gradual return to services. And even though we're not completely post-COVID, we're at the very least post-lockdown. And so we're looking at ways that we would make sure that our practices remain safe and that our practices remain open and people are being able to access healthcare properly. So the lockdown itself, I'm sure that what we went through is what most other people here went through. All elective work kind of ceased, and for us, elective work is heavy. We had to reduce staff numbers in terms of laying some people into working 3 times a week and some just working from home, but our emergency department remained open. And in those days, we did get a lot of COVID-like emergencies that came through the door. Now, post-lockdown, which is where we started to grab on, we're looking at ways of returning people safely to work. And that took a lot of thinking. With increasing number of patients from, I'll show the graphs of how patients dipped during the lockdown period, and then increasing complexities of conditions patients are seeking care for. A lot has been said and a lot will be continue to be said about medical tourism. During this period, we did see a lot of people who normally went abroad coming to us asking for care. And that for us was quite interesting. Some we could give care and some we could not give care. One of those areas that we really couldn't give a lot of care was in oncology. And it's actually brought to the fore very big gaps in our services in Nigeria, and where, like the president had said, people must deliberately invest in healthcare and let people have the option, at least the option of being able to get care in Nigeria. Because if the care is not available here, that becomes a problem. You don't then blame people when they have to travel. Again, to use oncology as an example, the whole West African sub-region does not have a PET scan. And a PET scan, a PET scan with the concomitant cyclotron that will provide the radiopharmaceuticals for use in the PET scan is the basic minimum you would expect in oncology care. And so I hope and pray that there will be people who would have to be able to invest in that. I have had to send patients to India and more recently to Kenya just to go get a PET scan and then come back to us. Initially, of course, there was a lot of need for us to do COVID testing, and in a very initial period, only the government centers could test. This also goes to lay credence to what has been said this morning already, that we must look at opening the healthcare space to government and private players. Whilst other countries were mobilizing all the resources to attend to healthcare, to the healthcare stress caused by the COVID-19 pandemic, in Nigeria here, we kept hearing that COVID was a no-go for the private sector. And here there were patients who were in their 60s, and for 40 years, they've never been to a government hospital. They've not been to a government hospital in this country, and you are telling them to go to government hospital because they are sick of COVID. It just didn't make sense. And a lot of them still ended up being treated in the private sector where they were used to traveling. So we had to get a lot of tests done, and eventually that would also speak to some of the decisions that we took earlier. Of course, I've already mentioned about reduced health tourism. People couldn't travel. But that did not immediately translate to the fact that we could offer people care. There were certain areas where we were hamstrung and were not able to offer care. And these, for us, are avenues for investments. So what changes did we have to make? As a hospital, and I'm going to be basing most of our discussions on the Gudu Hospital, on the Abuja Hospital. We had to make a lot of changes and a lot of investment as well, because you wanted to practice and you wanted to be safe. So first of all, we created a temporary holding area where once we suspected somebody had the COVID-19 infection, we held them until they could be evacuated. The second thing that we had to do is that we had to create a fully functional emergency theater. In our theater, usually we had emergency theater that was for minor procedures only, but we had to then, so every other procedure went upstairs to the 3 suites modular theater that we have upstairs in our facility. But in the COVID era, we had to make the investments to provide an emergency theater downstairs that could handle all emergencies. This was important because we wanted to keep our hospitals safe. In other parts of the world, hospitals were categorized into 2. Those that could accept COVID patients and those who could not. So you had the red hospitals or the green hospitals or the blue hospitals. And then the authorities looked at the resources available in every city and they were able to categorize hospitals. But we didn't have that here. So private practitioners like ourselves and like yourselves, we had to think of ways to make ourselves safe. And so we created a fully functional emergency theater just to be able to get by there. The next step we did was what I thought was a huge investment, but at the end of the day really became worth it. We had to create a molecular lab. We will all remember in the days 2020, looking at April, May, June, getting a test was really, really difficult. People waited 2 weeks for results. And I remember attending a meeting, there was a governor's forum meeting, and the question that was raised again and again was, how much is a COVID lab? Why does it have to be 2 or 3 centers in the country? And the answers I got, I wasn't quite sure that those were the answers that we should get. So as soon as I left that meeting that I was privileged to attend, I found out and I said, how much was the COVID lab? Because it then meant that if we didn't look for resources in the private space to be able to test ourselves, we were going to get in trouble. And so we made an investment and we opened a COVID-19 molecular lab. And that became something that really, really helped our group because even as we speak, we are still up to today sending people up and down the country to take samples and to test. The next thing that we did was that we installed 2 isolation and treatment centers. Again, you will recall that a lot of people could not get care because they could not get access to care. And for us, that was very, very disturbing. And the way we look at practice is we always ask ourselves, what if you were this patient? What if you were down? What will happen? I'm not sure how many people know that not a lot of people have been successfully ventilated of COVID-19 in this country. Not a lot of people. I'm not also sure whether we all know that one of the machines that could be used for the ECMO machine, ECMO machine, we don't have any in this country right now. And what we then found was that there were patients who could not get enough oxygen supply, oxygen flow. And we had 2 members of staff, ourselves, senior members of staff, who had gotten into trouble. But luckily we had made the investment. So we invested in 2 COVID-19 isolation and treatment centers, and we got them approved. So we became one of the few hospitals in Abuja that had approved molecular labs and approved isolation and treatment centers up to the point of ventilation if need be. So we did that, and this was in addition to all of the enhanced infection prevention and control practices that we all did and that we're all used to, where security men now have to check your temperature before you get into hospital. We have continued that practice to date, and we also had to get new IPC staffing to come in to be medical and some economic reasons for that happening, but we kind of prepared our outpatient service we reordered the rooms and just made sure that things were spaced out enough to make sure that there was a lot to keep patients safe. And we think we actually were quite successful at that because we kept most of our patients safe. So that's the kind of chart you're seeing. How this works. Right. So that's the kind of chart we've seen. We've taken a chart just to show graphically what has happened in a 30-month period. So that 30-month period goes from January 2019 to June 2021. And I think it's a very, very interesting period if you look at the charts. So these are the numbers of outpatient consultations that we had over the period. So if you go back to 2019 January, for us in Cedar Crest, we have a trend that actually mirrors the political situation in Nigeria. So usually January, February, the numbers come down. Because if you remember, in February 2019 was the elections. So our elections numbers come down and they tend to stay down and then they begin to bounce up by mid-year. That's the usual trend. And that's the trend that we have noted in 2011 and in 2015 and 2019. So that's why you see those numbers coming down. That's the first dip. Of course, at the point where that should have been going up, then COVID struck. So by April 2020, we came down to numbers of outpatient visits that we probably had last in 2009, 723 patients in 1 month. That was the lowest, and that would be, you know, most of them were emergencies, and most of them were patients we just could not turn away. But that was the number. And if you look at it, I think at the end of the slide, it's a bit cut off there. By June 2021, we have come back to numbers about 3,600 patients a month, numbers that have actually surpassed the pre-COVID year. Now, the interesting explanation, something you have to bear in mind, is that we usually see a peak of patients and a peak of business in the year following our elections. So if we had elections 2019, we tend to do about 30 to 50% more than previous 2018-2019 volumes in 2020. But that was not to be because of COVID, because we had the same impact in our business in 2016, and we had the same impact in 2012. So we always know that election years, we know what to expect. And the year after election, people are no longer talking about elections, and they're not saving money to buy votes. So people come to hospital and spend. So that's been our trend, but we can see the impact that COVID had in that trend. So outpatient service, this year already for 2021, we're already doing 20,000, and that's obviously going to be more than, and I think that we're probably going to approach instrumental to our success in the period. So I will still encourage private practitioners in your various facilities and environments to remember that the problems will not always go away, and as doctors, we're probably not in the best position yet to solve most of the problems that befall us, apart from our leader. So that's other leverage that we had, and we would diagnose COVID-19 infection either based on a PCR test or based on a scan. And we found that to be very, very useful. And many of these patients got on to receive proper care and got on to recover. And as you'll expect, there's usually a lot of arguments. I have done the COVID test and they said it was negative. Well, we showed you the scan and we said, this is COVID. And the way we did the number of COVID scans we did more than 100, we did hundreds of COVID scans. Many of our radiologists and many of our doctors could tell a COVID CT scan from a mile. We didn't need to train for that, we just knew how it looked. So the fact, again, that many practitioners did not make use of the CT scans. I think also put a lot of people at risk. And if we're seeing a situation where a third wave is developing, I will encourage people to be very, very liberal with the CT scan. I'd rather give patient a CT scan, give a patient a CT scan for free than say you will not do a CT scan because of cost. Because I think that that particular facility has actually been very, very life-saving. So again, if you look at the trends coming from 2019, looking at a 30-month period, there was that dip around the elections, and then COVID struck, and we had the lowest figures around there, and then things started to come back. Admissions started to come back from there, and up to this point, we're getting very high numbers of admissions. Most of these days, I would think in the last week, within this week, the emergencies have been full because of the strike. But prior to this, if you look at that, this is ending June. Prior to the strike, our wards have been full. So we are back to COVID, to the pre-COVID figures. And I expect, and I thought we would actually have been more than this. The numbers were more than this, if not for the COVID situations. Because like I said earlier, once we have elections, the next year or two after elections, there's always an uptick in numbers. Again, if you look at the numbers comparing to 2019, we're already hitting numbers that are close to 2019 by mid-year. So 2019, even though COVID impacted on 2020, we are seeing an upward trend in admissions. What of operations, surgical operations? Anybody who we're operating has to be COVID tested. That again, we've been able to do. How do we do with emergencies? We did rapid tests, the rapid antigen test for emergencies, but they still got the COVID test done anyway. And for some of these emergencies, like I said, we could get tests done within 6 hours. We phoned the lab, we called the lab. The lab is not the same location with the main hospital. We sent off a sample and we waited. But where we could not wait, we did the surgery in the emergency theater. Most orthopedic emergencies can wait. We had general surgical emergencies that were not able to wait. We had cesarean sections that just couldn't wait. We had a few other that just couldn't wait. But our anesthetists got provided the anesthetic hood, where they had to intubate, they wore the hood, and they took a lot of precautions. And then we actually assumed that the patient was positive. Interestingly, in this period, we got in more surgeons, some from abroad, and we got in more anesthetists, again, some from abroad. I know that the general trend is that more doctors are going out of Nigeria, but we still managed to get some back home. Some of those who we got from abroad were Nigerians, and some were not Nigerians. Some, because of the COVID situation and the lockdown in the UK, were not able to operate for the period. And so we used it. Is becoming a catastrophe in Nigeria, it's becoming a disaster. Right now, we're inundated with patients who need oncology care, oncology practices, and we just don't have them. Let's be clear that just buying a linear accelerator is not oncology care. Oncology care, like I said earlier, basic cyclotron, PET scan, and there's a lot that goes in. And we are just inundated with patients. We're doing the best we can for them. Some take a short trip and come back to continue their care, but we're having a lot of them. We're having a lot of complex cases that we can't look after. So I think over time in the past, we had actually relied on government hospitals to look after complex cases for us. But I'm really, really pleading with this association, with members here, to start saying that you have to take it over. You really, really have to take it over. In this period, we acquired, innovative equipment just to be able to help us to cope with cases. We acquired neuromonitors that allow us to do scoliosis surgeries safely. As far as I know, we're the third hospital in Nigeria to have neuromonitors. We've also acquired some of the nice, I don't recall the name now, that the special knife that they use for general surgery, just to be able to get cases by. But I do actually, and I want to make that point clear, that we're seeing a number of cases that ordinarily would be seeking help elsewhere, they begin to come to us. Interestingly, we're also getting patients from the sub-region. We've gotten patients in this period from Niger Republic, from Cameroon, and from Ghana, and from the Democratic Republic of the Congo. So these are areas that we really need to look at very, very carefully. So if you look at those figures again, 2019 February, the usual dip. Nobody wants to be in hospital having done an operation during the elections in case the country is set on fire, as you would expect. So that's what that dip we usually expect and we usually see. And then it goes up from there. By April 2019, yes, that's kept going up. And then when you look at April 2020, for us who are doing, both sides, medical side and the business side, April 2020 was an absolute disaster. I've never seen those figures in my entire life since we started practice. Those were low surgical figures. And when you have those kind of low surgical figures, it means that you're below the point where you can actually pay your bills. And that becomes a problem. But we don't pray and hope that we see that again. So those are low figures. Up to about this point, we probably, and then somewhere in March this year, I think we've got to about our highest peak, 100 and something, 62 patients operated in 1 month. But that's just a trend. And if the tempo goes on the way it is with the number of patients showing up for surgeries, and I dare say that unfortunately, again, because of the economic situation, surgical fees are going up, and we are also having more patients who are unable to afford surgeries. So if we put up the number of patients who we've made a diagnosis for and actually need operations, you'll be shocked. It's just a lot of numbers. We're looking at innovative ways of solving that. We're talking to NGOs. We're discussing far and wide. So if you have ways, if people who are nice-minded here, godly-minded, and you can have NGOs to support patients who need surgery and are not able to afford it, you'll be welcome to talk to us. Again, if you look at that, 2019, the COVID year 2020, things dropped a bit, but the way things are going in 2021, we're going to go beyond COVID year and we're going to go beyond 2019. Emergency service has been interesting as well. We've kept that open all through the period and with a very, very heightened index of suspicion. But we had to change a few things. In the past, if somebody had a community cardiac arrest, so what typically we call brought in dead, it's a community cardiac arrest, which means that when you got to hospital, you had no pulse, you had no respiration. We usually would resuscitate. And believe you me, we've been able to turn some people around at that point prior to COVID. But during COVID, we had to stop resuscitating community cardiac arrests because many of them were actually COVID. And then we said, we've got to safeguard ourselves, we've got to safeguard our practice. And if we lose 1 or 2 patients that we would have been able to resuscitate, we thought that was a reasonable price to pay. So that stopped, and then we had a very low threshold. And we saw patients coming and saying, I don't have COVID, I don't have COVID. We screen you anyway. So in situations like this, being able to rely, even if you can't have a COVID lab yourself, but being able to rely on a private practitioner who you can snap your fingers and get a test done keeps the entire practice safe. And I think patients just got that idea that if they came to us, they were safe. And so we actually screened a lot of people. If you're negative, that's it. And if you're negative and we still thought it was COVID, then you get a CT scan. You could get a CT scan 24 hours of the day. And like I said, emergency procedures were only done in the emergency theater. We had marked challenges with evacuation of patients right from the initial COVID era. Of course, we all recall in those days, you had to call the NCDC, who had to find the time, and a lot of time they put a lot of effort into it. to be able to come in and evacuate patients you suspected. But once we got our own treatment centers, that became easy. So even at 2 a.m., we could move patients. And the fact that we have about 5 ambulances right now made things easier. So we kind of were forced to prepare. So in the period as well, we invested in 2 new ambulances. We kind of were forced to prepare because we had this idea that we really didn't have a lot to rely on. I mean, one of the things I thought helped me as well was being part of the FCT COVID-19 team. We went around the hospitals, we saw the preparedness, and then I just came back to my guys and to my board and said, well, things are not looking good. We have to try and sort things out for ourselves the way we can. So eventually evacuations got better. And I really, really would encourage practitioners to evacuate early. We shouldn't hold on to things we can't treat. Many times you don't have to send to government hospitals. Sometimes you send to private hospitals. Sometimes you send to other hospitals. But if we have this culture of sending patients early, not at the last minute, then things will be a lot better for us. So that's just, to say a bit about our emergency service during the period. Radiology service, I talked about that as well. We installed a radiology machine as a CT machine about 2014, just to give you an idea of the numbers. And by 2019, end of 2019, our tube was at 50% capacity. In the last 18 months, we have blown our tube. We've got to the point now where the tube has to be replaced. So what the tube did in 18 months is about what the tube did in 5 years. But we've got to be safe. So we made sure that that service kept running, because if you check all the literature, the CT scan of the chest was very, very useful in COVID care, and we didn't spare to use it as well. So that also was very, very useful for us. COVID-19 testing, we talked about that. Medically indicated tests was the reason why we actually went to the forefront to invest in COVID testing. But shortly after that, like we know, government then said that the private labs were the ones to do all the traveling tests. So about 90% of our COVID testing done at the Guarimpa facility right now is travel testing. So they're not medically indicated testing for people who want to travel. But the fact remains that we still remain very, very safe, because we have that backup, and it's one of the things that we ramped up in the period. Going by the way that COVID is going, I think practitioners in the house should still invest in COVID testing. It's a very useful, molecular lab is a very useful tool. If you can partner, nothing stops 5 or 10 practitioners from coming together to doing a molecular lab. We have one molecular right now, but before the end of the year, we're going to do more, because the numbers seem to show and the direction seems to show that as far as testing for healthcare and testing for traveling goes, there's going to be more to do with that. So in conclusion, ladies and gentlemen, I think it's been a very challenging period. A lot of innovation has been required, a lot of business thinking has been required to survive well in this period. I'm sure that the COVID situation and the post-COVID situation has impacted on a lot of our practices, and we're still watching as things carefully evolve. Is one area that people need to really keep their eyes in the news. We need to know what the news is doing at each time. People's response to vaccination has not been fantastic. For our frontline COVID staff, we made sure that they were vaccinated, right on. We didn't give many options about that. If you watch the news, this morning I heard that there were quite a lot of COVID deaths in Lagos. Unfortunately, that number is not replicated in the incidence reports that we get. But it does look like we are approaching the 3rd wave, or we're already in the 3rd wave. It's always argued that Lagos is the epicenter of COVID in Nigeria. But I don't seem to agree, because the FCT has 1/3 the number of Lagos, and the FCT has maybe less than 1/3 the population of Lagos. So when you look at population and number of positives, you will then begin to wonder whether the Federal Capital Territory is not actually ahead of Lagos. So I think that there's still a need for heightened care. I think that we still need a lot of business intelligence. Which part of this should we invest in? What should we push forward? And what shouldn't we? And I think that as doctors, as business people, we need to think very carefully about the choices we make. It's interesting that it's been mentioned about government support, health bank, things like that. We just keep praying and pushing and hoping that some help will come. Naira has taken a bashing, so for people who are thinking of buying equipment from abroad, the investments are no longer making a lot of sense. We are going to be investing into a 1.5 MRI machine, but we've looked at the numbers now with the current exchange rate, it makes no sense. So COVID-related innovations and adjustments would need to continue to be made, because if you look at again at 1918, that took 4 years. It was 1918 to 1922. We're hoping, who knows, 1919 to 1923 or to 1924, we don't know, but it does look like we have at the very least, despite vaccine, and if you follow what's happening in other parts of the world, the US and the others, at the very least, we have another 2 years to go. Thank you very much for listening.
We can do better than that. Thank you very much, Dr. Felix Ogedegwe.
Thank you, sir.
That was a great one. We're really blessed. Can we be seated, please? It's been a very educating lecture. We appreciate you for taking your time. Deliver the 43rd and the Mewa lecture. We are highly honored. Thank you very much. So while the lecture was going on, our special guest of honor walked in. Permit me to introduce to you the National President of the Guild of Medical Directors, Professor Femi Babalola. A round of applause for him. Also, he walked in the Secretary General of the Nigerian Medical Association, the engine room of the Nigerian Medical Association, and my oga at the top, Dr. Philip Ekpe. You are welcome, sir. Okay, distinguished ladies and gentlemen, delegates to the 43rd Centenary Annual General Meeting of the AGPMPN. We have come to this point. This is one of the highlights of today's event, and that will be the proceedings for the award of the Fellow of Association of General Practitioners of Nigeria. So I would like to invite Mr. President to come over to the podium to confer the award on the recipients. Permit me therefore to invite the President, Dr. Ike Odu, DMP, to proceed to the podium for the conferment of the award. DJ, give me volume here, please. Mr. President, sir. Distinguished ladies and gentlemen, at this point, I, Dr. Chinedu Okoro, Secretary General of AGPMPN, I hereby present the following doctors who, for their contributions to the growth of the general Dr. Onyekesi from Rivers State, Anselm Chukwu Jindu. A round of applause for him, please. Step forward. I pray that their names be entered into the association's roll of honor. Now we will take your oath. Dr. Sir, do you hereby promise to accept the responsibilities of the Fellow of the Association of General Practitioners? I do hereby solemnly declare that I accept this honor by my peers and colleagues. I also promise to discharge my responsibilities as a fellow of Association of General Practitioners. So help me God.
Please. I, hold on. I, Dr. Ike Odo, President of the Association of General and Private Medical Practitioners of Nigeria, have the honor to formally confer you as Fellow of the Association and hereby present these certificates which entitle you to the rights and privileges pertaining thereunto. Congratulations. Dr. Oshodi Musa Olakunle, in recognition of your very outstanding contributions to the growth of the healthcare industry in Nigeria, on behalf of your peers, I confer upon you the award of Fellow of the Association of General Practitioners. Dr. Onyekesi Anselm Chukwu Jindo, in recognition of your contributions to the development of the healthcare system, I, Ambassador Dr. Ike Odo, on behalf of your peers, confer upon you this day, 11th of August, 2021, with the award of Fellow of the Association. Congratulations.
So you proceed to the secretary to sign the roll of honor. Thank you very much. Congratulations. Congratulations. A round of applause, please, for them. He will come. He will come.
Documents of AGPMPN.
Okay, you mentioned there are two. So, distinguished ladies and gentlemen, please let's move forward. At this point, I would like to invite our special guest of honor to come forward and declare the annual general meeting open. He's coming to stand on behalf of the Honorable Minister of Health, Dr. Osagie Hanire. There is no person than our special guest of honor, the National President of the Guild of Medical Directors of Nigeria, Professor Femi Babalola. Please come forward, sir, to declare the AGM open. Come this way, sir. A round of applause for him, please. The high point on this event.
Good afternoon, ladies and gentlemen. My brothers and sisters, I bring special greetings from the Guild of Medical Directors. I have been asked to stand in the stead of our Honorable Minister, who unfortunately is caught up in the usual Federal Executive Council meeting, which normally holds on Wednesdays. I'm sure that we're all aware of the issues concerning the strike of the NARD doctors and so on. So perhaps that is what is holding him back, we don't know. But all the same, it is my extreme pleasure to be here this afternoon. And I want to congratulate the Association of General and Private Medical Practitioners of Nigeria on this centenary occasion. But when they told me that the AGPMPN was already 100 years old, it occurred to me that the AGPMPN is actually older than the Nigerian Medical Association itself. And I think we need to give ourselves a clap offering for that. Because the NMA itself was officially started maybe around 1963, if I'm not mistaken. So it has been 100 glorious years of service to our motherland, as represented by our association. I also understand that this is the 43rd annual general meeting and scientific conference, which is holding in our capital city here in Abuja. And as a resident of Abuja, I also want to welcome all of us to our quiet and beautiful city. Those of us who are coming from Lagos will immediately see the difference in terms of how quiet the place is. There's nowhere that is too far in Abuja here that you cannot reach within 10 to 20 minutes. Traffic is not too bad either. So you are very much welcome to this city if you are coming from outside. Let me especially congratulate my brother, Ambassador Dr. Ike Odo, who is the president of the AGPMPN and who is doing a very marvelous job in leading this very important association through these challenging times. Myself, representing the leadership of the Guild of Medical Directors and Dr. Odo, we have been in the trenches together on a number of occasions. We have had to go to the minister together. I've had to go to the National Assembly together on several occasions. We have had to join our positions on one or two issues that confront us as private practitioners in Nigeria. And I've seen that it's a very formidable and dogged fighter for the rights of private practitioners in this nation, and indeed, we are very lucky to have him as a leader of this august association. My brother, Dr. Melitos Abonyi, the Secretary General, is also somebody who we are both in Abuja here. We have been together in this city for a long time, and our families are, interwoven on several levels. I also want to congratulate him on putting this very important meeting together. Walking through the grounds of this meeting place, I could see that there are many organizations who have set up their advertisement booths. And just from what I could see, I know that a lot of work must have gone on behind the scenes to put this meeting together. From Cedar Crest, Dr. Godegbe. Of course, one of the things he said was that we are not in the post-COVID-19 pandemic era yet. We certainly hope we will get there, but we cannot afford to let down our guard at this time because the new variant of the Delta variant is much more virulent than the Alpha and Beta variant we have had to deal with in the past, and also the Epsilon variant. And so we still have to be on our guard. So unfortunately, I must say that we are not yet in the post-COVID-19 pandemic era. But I pray to God that we will get there soon enough and we'll be able to relax. If you ask me personally, my feeling is that we're likely to have to live with COVID. It's not one of those things that I believe that will go away. So I'm sure that one of the things we're going to be looking at this meeting are ways in which we as private practitioners can cope with this problem. One of the things that Dr. Felix said was that they did a COVID-19 test for every patient who was going to be operated, I believe. That is one way to look at it. Another way to look at it is to assume that every patient has COVID, which is what you call the universal precaution. I, for one, when I'm operating on any patient, I generally put them on ivermectin prophylaxis for 1 or 2 days before they come to the theater. So we all have to find ways in which we cope with this pandemic, and I pray that God will see us through. We have lost too many of our members to this pandemic, and I pray that it will come to a stop, even as we continue to live with it. I also want to congratulate the AGPMPN on the 10 billion private sector healthcare intervention fund, which was launched a couple of months ago. And I think there's going to be a ceremony tomorrow to further bring it to the public purview. An important component of this private sector healthcare intervention fund is the Save 1 Million Nigerian Mothers initiative. All these are very laudable initiatives. And Professor Innocent Achanya Abuja, the president of the Nigerian Medical Association, and also the Secretary General of the Nigerian Medical Association, Dr. Uche Phillips, who is one of our brothers in the Guild of Medical Directors, for the work that they are doing in the NMA, which is, of course, the parent body to both the Guild of Medical Directors and the AGPMPN. I pray that God will continue to strengthen them even as they fight for the right of medical practice and medical doctors in this nation and through these difficult times. Without further ado, it is my honor and privilege, therefore, to declare open the 43rd Annual General Meeting and Scientific Conference, dubbed Abuja 2021, a centenary edition of the Guild of the Association AGPMPN. I wish you a very successful meeting. I wish you further gained knowledge. I wish you further insights into the care of our patients, who are the reason why we are gathered here today. Thank you very much indeed.
I think we can do better than that for Professor Babalola, our special guest of honor. Thank you very much, sir. With that, I would like to invite the chairman of our local organizing committee to briefly, in just 3 minutes, welcome us again to Abuja. COC.
Good afternoon, ladies and gentlemen. There have been very great speeches here today, so I'll be very quick and fast with mine. I welcome all delegates to this very important meeting. All delegates, our spouses, and our guests to this very unusual conference. It's unusual in several aspects. It's our centenary celebration. 100 years is a lot in the life of any association. So we are rolling out the drums in celebration. It's also unusual because this is a COVID era. Our brother, our friend, Dr. Felix Ogedengbe has emphasized it. I'm sure everybody listened. I did. He is my colleague in the FCT Ministerial Committee on COVID. And for us to be able to drag him out to this lecture alone was a massive program. I know how scared he was at the beginning. Somehow, I think he started mustering some courage. Dr. Godebe, you're welcome. I appreciate you. Another person who was also extremely scared and worried about COVID is our brother and friend, Professor Femi Babalola. Thank you for coming, and thank you for declaring our conference open. I appreciate you. It's unusual, I said, because it's a COVID era. We've had to postpone this conference and reconvene today in the light of what is happening all over the world. It's unusual in the fact that I'm the LOC chairman by default. The chairman of the local organizing committee was supposed to be the chairman of Katsina, Kaduna, and Nasarawa states. Those my brothers, those of them who are around here, please, can you join me here for recognition? Please, Dr. Bute, Dr. Zumba, and the Katsina chairman, please. It's actually a show that I have stolen. You must appreciate. Thank you so much for coming up. Dr. Bute is here, I've seen him. Dr. Zumba, please. And the Katsina chairman, thank you so much for this solidarity. These are the men who are supposed to be LOC chairman. Thank you. My friend came all the way from Katsina. Thank you for coming. Please, these are the men that you are supposed to be hearing their voices, not mine. Please, a round of applause for them. Thank you. Our leaders have had to move us to Abuja in the light of our nation's recent security challenges. In retrospect, it shows that our leadership have been right and proactive and should be commended. Please, a round of applause for the NOC. Thank you, my brothers. Thank you, my sister, who is in the LOC. Having given this scenario, I wish to warmly and sincerely welcome you to our nation's beautiful capital city, Abuja. The city is serene, compact, and beautiful, and I urge you all to luxuriate in it. Leave your worries and practices behind where you came from, and be part and parcel of this moment. I can assure you that the practices will be there when you get back to them. And indeed, the knowledge and the exposure you would have gained here will prosper you and the practice. No effort was spared in making you comfortable here. Our indefatigable president, Dr. Ambassador Aikodo, and the National Officers Committee, NOC, have been crisscrossing the length and breadth of this country to make these celebrations come to fruition. And here we are. Opening addresses are supposed to be like a woman's mini skirt, short enough to attract attention and long enough to cover the subject matter. In the light of this, ladies and gentlemen, the press, our friends, our colleagues, indeed even our adversaries, I welcome you to Abuja and wish AGPMPN a resounding AGM, International Scientific Conference, and 100 years of celebration. We'll keep dancing. You're welcome. Thank you very much.
Thank you very much, our COC chairman. It wasn't as brief as I thought, but you tried. Okay, thank you very much. Thanks for hosting us. So distinguished ladies and gentlemen, the session will continue. We'll take some one or two presentations briefly. Somebody lost a bag from Cross River State. So in case you see any bag around you, it has some historical documents, please bring it forward to the secretariat. Let me call on Vivian Waka. She has a gift for us. You just have 3 minutes to tell us about the gift and you can go. Just you, just the gift. We want to hear, no other thing. Vivian Waka is the CEO of MedSaf.
Okay. Good afternoon. I'm so honored to be here. So thank you for the opportunity. I was definitely moved by a lot of the speeches a little bit earlier. So I just to tell you a little bit more about MedSaf. MedSaf was launched in 2017. We are a pharmaceutical technology company. So we're looking at how can we leverage technology and data analytics to make sure that your hospitals, the clinics, the pharmacies, the diagnostic centers, that everyone providing healthcare in Nigerian context, as well as in the African context, can have access to safe, affordable, quality medications in real time, right? So we at medsaf.com have created a series of programs and various things to help make your lives easier. I see some of our customers who've worked with us for many years, and even just some of our recent customers such as Cedar Crest, Abuja, so we're just really happy to be here and to offer you the best that we can. We have a new program, it's called MedSaf Assure program. And that program basically is focused on streamlining the medication costs for your hospitals and your clinics. One of the worst things that we've seen happen the trends that we've seen happen over the last couple of months, if not years, is the stocking out of crucial medications and the inability to really see, medication prices, be stable. We see them consistently fluctuating. So we've actually created a program called MedSaf Assure program that can help you lock in medication prices for your hospitals and pharmacies. So you definitely want to check that out at our booth and sign up so that we can make sure that your hospital or pharmacy or clinic has access to the medications that you really need right on time. So that's just really important. Also, we have what's called the MedSaf Platinum Partners Program. So for example, Cedar Crest, is a good example. We would actually invest money and resources into making sure that your procurement, that you have everything that you need right in time. And so that's another program that MedSaf specializes in. We also import consumables as well. So we're working with, a lot of the diagnostic labs now to make sure that you have better pricing on your consumables. So that is an area where you can save money. So we're doing a lot. All you have to do is go to www.medsaf.com, medsaf.com, and sign up. We deliver across the country. We aggregate service providers, logistics companies to make sure that your medications can get to you in Lagos, 48 hours, across the country, 72 hours. So check us out. We do have some winners. And first of all, I want to thank all of the hospitals that actually already signed up to the MedSaf Assure program at our booth. We've had a ton of signups from this conference, so we really appreciate that, and we can't wait to serve you. And we do have a winner of 100,000 Naira. Okay, so he's gonna announce.
We will do justice to that. You're welcome, Doc.
My slide. Yes, I have. Okay. Good afternoon, distinguished colleagues.
I bring you warm greetings from the oil city of Warri. I would like to thank the organizers, AGPMPN, as well as Ferrin, for giving me this opportunity to share a few things concerning ovulation induction using gonadotrophins. It's actually an area where I think that as private practitioners and general practitioners, we could be creating value and extracting value for our infertile patients. So that's my outline. Infertility affects 1 in 7 couples worldwide during their lifetime. The reported incidence in institutions in our environment will range from 15 to 49%. Approximately 25% of these will have an ovulatory disorder. Ovulatory disorders represent the simplest form of infertility to treat. It's a procedure that I think primary care doctors can take advantage of in helping our patients. I'm sure we are all familiar with this, the hypothalamo-pituitary-ovarian axis. GnRH secreted from the hypothalamus stimulates the pituitary to produce the gonadotrophins LH and FSH, which in turn stimulates the ovaries to cause recruitment, growth, and eventual maturation and release of the oocytes. The oocytes during their maturation also produce estradiol progesterone, which in turn have a negative feedback effect on the hypothalamus and the pituitary to reduce the production of gonadotrophins. At a critical time during the mid-cycle, rising estrogen levels can also produce a positive feedback effect at the level of the pituitary, leading to what we call the LH surge and eventual maturation of the oocyte and its release. Well, ovulation induction drugs are divided here into anti-estrogens. I'm sure we are familiar with them: clomiphene citrate and tamoxifen. Then the aromatase inhibitors, letrozole and anastrozole. The advantages of these are that they are cheap, they are taken orally, they are also readily available. Even some of our patients take them before they come to us these days. They buy them over the counter. Then you also need limited monitoring. You can take this without necessarily monitoring. And they have decreased multiple pregnancy rates and reduced risk of OHSS, which is one of the most dreaded complications of ovulation induction. The disadvantage, especially for clomiphene citrate, is its anti-estrogenic effect on cervical mucus, and that leads to a decrease in pregnancy rates, which means though it may cause ovulation, the pregnancy rate is less than the number of times that it induces ovulation. Gonadotrophins are actually glycoprotein hormones produced from the anterior pituitary. They involve FSH and LH. There are 3 commercially available ones. The HMG, human menopausal gonadotropin. There's a highly purified human menopausal gonadotropin, and then the recombinant FSH. The advantages of these are that they represent the final common pathway, so they actually stimulate the ovaries to produce the follicles. So where other modalities may have failed, they can still succeed. But their disadvantages are the fact that there's increased multiple pregnancy rates, there is a greater need for monitoring, and the risk of OHSS is much higher. And they're also given only as injections. The hallmark of anovulatory cycles are irregular menses. The principles of management of infertility due to anovulation involve correction of the fundamental problems, things like anorexia nervosa or stress. Then to optimize the health of the patients, for some PCOS patients, we may have to ask them lose weight before they can go on ovulation induction drugs. The objective of ovulation induction is induction of monofollicular growth. And these are some of the investigations that we need to do: the 3 FSH, LH, prolactin, estradiol level, TSH level. And HSG is also very important because we really will not have any business inducing ovulation if the tubes are blocked. Then the seminal fluid analysis is also important in order to rule out severe sperm abnormalities, because those patients will be needing a higher level of care to take care of them. On the basis of FSH, LH levels, WHO has divided anovulation into hypogonadotrophic anovulation, where the level of gonadotrophins are low, normal gonadotrophic anovulation, the level of gonadotrophins are normal, and hypergonadotrophic anovulation, where the levels are very high, in cases like patients who hit the menopause or who have premature ovarian failure. So these are some of the protocols we use for clomiphene citrate, which is the most commonly used drug and more commonly available. Day 3 to 7, the doses are 100 to 150 milligram. Then we scan on day 12. The scanning, transvaginal ultrasound is preferable. We want to know the number and sizes of follicles, as well as the endometrial thickness. We trigger with HCG when we have at least one follicle that is 17 millimeters or over and endometrial thickness of 7 millimeters. If we don't get a reaction, if there's no response, then we'll need to stop and increase the dose of clomiphene citrate in the next cycle or move on to the use of gonadotrophins. Letrozole is another drug that we can use, an aromatase inhibitor. Aromatase is the enzyme that converts androgens to estrogens, and the absence of estrogens removes the negative feedback effect, and so we have more gonadotrophins secreted. The dose is as we can see. We start from day 3. We use 2.5 to 7.5 milligrams daily, and then we do our scan on day 11, looking at the number and size of follicles as well. We can also use gonadotrophins either as step down or step up. Step down will start with a smaller dose and watch how the follicles are developing, or step up will start at a higher dose and watch how the follicles are developing, and then we reduce the dose as the follicles respond. We can also use a combination of clomiphene citrate and either clomiphene citrate and letrozole and HMG. In my practice, I tend to use clomiphene citrate along with gonadotrophins. It helps in reducing the dose of gonadotrophins that you may eventually need to use, because those are really very expensive drugs. While monitoring, there may be need to cancel cycles when patients over-respond. If you have more than 3 follicles that are 17 millimeters, you should actually cancel that cycle, in which case the next cycle you may need to reduce the dose that you are using for the patient, or you have more than 6 follicles that are 14 millimeters or more. The criteria do vary from center to center, but sometimes you may need to look at the entire picture of the patient in order to take the decision. Like if I have a patient that is in the twilight of our reproductive career, and I'm getting even more than 3 follicles, I may still want to go ahead because there's a natural process that will reduce the number of eventual embryos that can implant. So for those who have type 1, the common treatment is pulsatile gonadotrophin releasing hormone. We can also use gonadotropins. For these patients, the human menopausal gonadotrophin is the preferred gonadotrophin. If we are using the recombinant FSH, there's a need that we'll need to use very high doses. There's decreased follicular growth, and then overall ovulation is also less. So how many cycles should we be doing? Maximum 3 to 6 clomiphene citrate, then minimum of 3 cycles of stimulation using HMG. Then on the total, we can do up to 12 cycles. After 12 cycles, that patient needs to be referred to a higher level of care, maybe requiring IVF or some other kind of treatment. Laparoscopic ovarian drilling is also a method that we can use for ovulation induction. There's no difference really between laparoscopic ovarian drilling and use of HMGs in places where these are readily available. But we know that in our setting, the skill and the equipment for laparoscopy is still not readily available. So that decision for us is usually simpler. So what are the complications of ovulation induction, especially when we are using gonadotrophins? Two of the most dreaded are ovarian hyperstimulation syndrome, a situation where you have bilateral enlarged ovaries associated with increased test space loss of fluid and hemo concentration. So such patients may have abdominal distension from ascites and also a hydrothorax. It's a complication that nobody really wants to see at all. Then we can also have higher order multiple pregnancies. What can GPs do? GPs can actually be involved in ovulation induction and timed intercourse. You stimulate your patients and you tell them when to meet. Once the follicles are mature and you trigger, you can tell the husband and wife exactly when to meet. The only disadvantage is that sometimes it can create pressure and the man may have erectile dysfunction. Then ovulation induction and IUI too. It's also a very simple procedure, low technology. You can be taught how to do sperm swim up within your office setting, and you can inseminate your patient following ovulation induction. So this is a study comparing highly purified human menopausal gonadotropin and recombinant FSH in patients with type 2 WHO and ovulation. As you can see, the pregnancy rates are similar. The ovulation rates are similar. The pregnancy rates are similar. And the singleton pregnancy rates are also similar. But if I go down, you will see, if you look at the OHSS, you see that you have a higher risk of OHSS using the recombinant FSH, and the multiple pregnancy rate is also higher. This is for ovulation induction. This is another study looking at IUI. If you look at these two, the pregnancy rates are also similar, and the dose of gonadotrophins is a bit less when you're using the HMG, like as I pointed out before. But if you look again at the bottom, you will see that the intermediate follicles and the number of follicles on the day of HCG trigger is also higher with the recombinant FSH. And this has implication in terms of OHSS. See, the OHSS rate is very high here, 8.4% compared to 1.2%. And the multiple pregnancy rate is also significantly higher. So in conclusion, ovulation induction is one of the arsenal in the repository for management of infertility secondary to anovulation, and could be a useful tool in the hands of general practitioners in assisting a number of our infertile couples. Knowledge of the various protocols and safety measures will aid in safety of its use. Thank you very much.
Thank you very much, Doc. That was a good one. Quickly, let me call on the representative of Novo Nordisk to talk on the initiation of insulin therapy with premix insulin. Dr. Kweme Chinonso, step up, please. Please, I want to appeal with us to be a bit patient. Lunch is being prepared. I will inform you immediately lunch is ready. Dr. Kweme.
Good afternoon, everyone. Mr. Chairman, the President of the Association, I'll be leading the discussion on initiation of premix insulin in management of type 2 diabetes. So, is the slides ready? So while we're waiting for the slides to be ready, we know that diabetes is a major global non-communicable disease. And the underlying problem in people with diabetes is deficiency or insulin resistance. Okay. So this symposium is sponsored by Novo Nordics, and you should change it from there. It's sponsored by Novo Nordics. My name is Chinonso Ekweme. I work at Federal Medical Center, Jabi. So I'll be leading the discussion on initiation of insulin premix therapy with premix insulin. We'll look at the burden of diabetes and also the clinical importance of clinical inertia when clinicians have a delay with initiation or intensification of treatment in people with type 2 diabetes. So diabetes is a global problem. Over 700 million people are expected to have type 2 diabetes by 2045. 4.2 million persons had died from diabetes in 2019. In Nigeria, about 3% of individuals of the population have type 2 diabetes, and that figure is expected to increase to 6.5 million by 2045. It means that clinicians, especially the general practitioners, have a huge role to play, a huge burden of disease to bear, to manage with regards to type 2 diabetes. And every day, about 175 people die from diabetes. Whereas the International Diabetic Federation, postulate about 3% of Nigerians have diabetes. But local studies done in Nigeria shows that about 5.7% of Nigerian population have diabetes. And it seems that there's a correlation between diabetes and areas where we find oil and gas, as shown in this graph, that people from South-South have the highest prevalence of 9.8%. So the key abnormality in diabetes is lack of insulin or relative deficiency of insulin with regards to type 2 diabetes, alongside other mechanisms. So because of that deficiency of insulin and also insulin resistance, what happens is that there's increased output of glucose by the liver. The muscles are not able to take up blood glucose. This ultimately leads to increase in both the fasting and the postprandial blood glucose. So it's good to establish that type 2 diabetes is a progressive disorder, meaning that from diagnosis, there's a progressive loss of the cells that secrete insulin. So this is important because at diagnosis, we should be able to educate our patients that, look, for those who have type 2 diabetes, that it's a progressive disorder. Oral medication over time may become inadequate to control the blood glucose, and ultimately, patients may need insulin. And it's important to also state that for some patients, before the diagnosis, some of the complications of diabetes would have set in. So a very important study, UKPDS, found that most people with type 2 diabetes 6 years down the line would require insulin for adequate blood glucose control. So what happens when clinicians, doctors, don't initiate therapy early with regards to the blood glucose control? What we refer to as the clinical inertia, which is when doctors delay to intensify or to upgrade treatment with regards to the blood glucose control. Now, the consequences of this is that it leads to both the micro and macrovascular complications, which includes the diabetic eye disease, lower extremity issues, heart failures, myocardial infarctions, as well as stroke. So it's important that clinicians, especially general practitioners, know when to intensify or initiate insulin to achieve good glycemic control. So we know that the role of HbA1c in management of type 2 diabetes, a 1% drop in the glycated hemoglobin brings about 43% reduction in amputation, 16% reduction in the risk of heart failure, as well as 4% reduction in the risk of stroke. So intensifying and initiating insulin treatment is a critical aspect in management of patients with type 2 diabetes once it's indicated. And we know that among all medications, the most effective in reducing HbA1c is insulin. So whereas other medications are important in management of type 2 diabetes, insulin is the only agent, because that's like replacing what the body needs to control the blood glucose. So what are the things we consider when we want to initiate patients on insulin? This includes patients who have osmotic symptoms of hyperglycemia, if there are complications, fasting blood glucose greater than 13.8 millimoles per liter, postprandial blood glucose greater than 16.6, if patient has been on oral antidiabetic for some time and control is inadequate, and of course, pregnant women with gestational diabetes. So usually the guideline states that HbA1c, patient with HbA1c greater than 8.5 to 9.2 is at that reference range that we want to initiate insulin therapy. And I know that we're all used to, or we're more conversant with the role of fasting plasma glucose, but suffice to say that there is this unholy triad between the fasting plasma glucose and the postprandial blood glucose. Both give rise to the glycated hemoglobin. So fasting plasma glucose is important in monitoring treatment, as well as the postprandial blood glucose, as we'll see in the next slides. So in choosing regimen that can control the blood glucose, it's important to look at medications that can address both the fasting and the 2 hours postprandial, what we refer to as the postprandial blood glucose, as both of them contribute to the glycated hemoglobin. Now, elevated postprandial blood glucose is associated with cardiovascular risk, retinopathy, decreased myocardial blood flow, impaired cognitive function, especially in our elderly patients. So when we're evaluating patients with type 2 diabetes, or with diabetes generally, it's also important to look at the postprandial blood glucose level. So what premix options can we use to treat patients with type 2 diabetes? Next slide. Okay. So I'm sure a couple of us have had lunch or will soon be having lunch. And it's important to say that in the human body, it secretes insulin in 2 major fashions. There's a continuous insulin secretion called the basal insulin secretion, as well as postprandial insulin secretion that is done each time an individual eats. So the basal insulin secretion takes care of the fasting plasma glucose, as well as in-between meal blood glucose, whereas the prandial insulin secretion takes care of the immediate calories that we may have taken. So an insulin, we know, is a molecule that has that consists of 2 amino acid chains and linked by disulfide bridges. So the human insulin is, is tailored towards the physiologic insulin. The only major difference here is that it is produced by recombinant DNA technology. There's also a type of insulin we refer to as insulin analogs. These are similar to human insulin. The major difference is that an amino acid sequence has been substituted to give an insulin that has better pharmacokinetic and pharmacodynamic profile. So the insulin analogs have better efficacy with regards to better HbA1c control, safety because they have lower risk of hypoglycemia, and they are a little bit more flexible and more convenient to administer. So what strategies should we adopt when we want to initiate patients on with insulin in type 2 diabetes? So insulin can be initiated via the basal insulin mode, where insulin is given once or twice a day. It can also be initiated as a premixed insulin, given once, twice, or 3 times daily. And also insulin can also be initiated when indicated at meal times. But what factors do we need to consider when we want to initiate patients on insulin? Now, if a patient's postprandial blood glucose excursion is greater than 3 millimoles, such a patient would benefit more from the premixed insulin. Now, if a patient has ability to, or less likely going to be able to use insulin 4 times a day, as you have in basal bolus, and patient will prefer insulin like twice a day, such patient will benefit more from the premixed insulin. For individuals, especially in our culture, where people have 1 or 2 large carbohydrate meals, such a patient with type 2 diabetes will benefit more from the premixed insulin. And if a patient has a predictable lifestyle, such person will benefit more from the premixed insulin as against the the basal insulin. So, and most international guidelines recommends the use of premixed insulin as one of the initiation strategy for management of type 2 diabetes patients. This includes the International Diabetes Federation, Canada Diabetes Federation, as well as the NICE guidelines. So, what are the types of premixed insulin we have in our environment? There are human premixed insulin and also premixed analogs. The human premixed insulin include the Mixtard 30, Insuman combo, as well as the Humulin 3070 insulin. For the premix, we have Novomix 30, Humalog Mix 2575, as well as Humalog Mix 5050. So we'll delve into the practical guideline on how to initiate a patient on insulin using the Mixtard 30, which is a biphasic human insulin. Mixtard 30 consists of 30% of soluble human insulin and 70% of neutral protamine hexagon insulin. Now, addition of protamine to soluble insulin makes the molecule to have a slower onset time as well as delay the action time of the insulin and also prolongs the duration of action of the insulin. So, and Mixtard consists of 30% of soluble human insulin and 70% of MPH. So because of the delay in onset time of Mixtard, which is about 30 minutes, the Mixtard insulin is preferably given 30 minutes before food. It peaks within 2 to 8 hours and has a duration of action for 24 hours. So the duration of action of Mixtard is 24 hours. So how do we initiate insulin using Mixtard 30? So for initiation, we use the dose 0.2 to 0.3 international units per kg per day and give 2/3 of the dose with breakfast and 1/3 with dinner. Usually, once insulin is initiated, it's advisable to withdraw the sulfonylurea such as glimepiride, glibeclamide, gliclazide, and glipizide. Metformin can be continued with patients who you place on Mixtard insulin, and we titrate the dose of insulin based on patient fasting and 2 hours postprandial blood glucose. So Mixtard comes in vials and also in pen device, which is more easy to administer. Usually it's stored at temperatures between 2 to 8 degrees before use. Once it's opened, it should be stored at room temperature and should be discarded after 1 month. So I'll discuss a clinical case scenario showing how Mixtard can be initiated in patients with type 2 diabetes. So in my clinic, we had this patient, a 53-year-old female who was referred from the general outpatient clinic. She had a body mass index of 31 kg per meter square. Her weight was 90 kg, and her blood pressure was 124/70 at presentation. Her baseline blood glucose profile, her fasting blood glucose was 9.3 millimoles per liter. Mean 2 hours postprandial was 14.4. HbA1c was 11%. You could see that based on the glycated hemoglobin, control was poor. Both the fasting and the postprandial blood glucose were not good enough. She was on metformin 1,000 twice a day and glimepiride 4 milligrams once a day. She's also on statin and all of that. The other important thing is that patient was not exercising as well as was not keeping good blood glucose monitoring records. So what did we do? We initiated Mixtard at 0.2 units per kg per day and gave 2/3 of that with breakfast and 1/3 with dinner. We continued the metformin, but discontinued the glimepiride. And we set a blood glucose target of fasting of 4 to 6 millimoles per liter, postprandial blood glucose of 4 to 9, and glycated hemoglobin target of 6.5%. And also taught the patient on how to titrate the insulin. 6 months later, the average fasting blood glucose was 5.2, and postprandial blood glucose was 6.8. Glycated hemoglobin has dropped from 11% to 7%. Of course, we continued the statin and also the aspirin patient was on. We gave additional educations on medical nutrition therapy and also educated the person on hypoglycemia. This is important because all diabetic patients should have proper education on management of hypoglycemia. Right. So the next thing we'll look into is initiation of insulin therapy using the premixed insulin, Novomix 30. Novomix 30 is a premixed insulin analog. In aspart insulin, the proline in chain and beta chain of 28 has been substituted with aspart, giving an insulin aspart that has fast onset of action and rapid absorption. So biphasic insulin analog Novomix 30 consists of 30% of soluble insulin aspart, which is a rapid acting insulin, as well as 70% of protamine crystallized insulin aspart. Let's also remember that addition of protamine to insulin delays the duration of action of the insulin and also delays the onset time. The same principle is also deployed in the premixed human insulin mixed at 30. So, but the key difference between the analog insulin and the human insulin is that with the analog insulin, like Novomix 30, onset of action time is 10 to 20 minutes. So patient can actually have it just before meal, unlike the human insulin where it ought to be taken 30 minutes before food. Peak action is about 1 to 4 hours, and duration of action is similar, about 24 hours. So with the premixed insulin analogs, there's lower risk of hypoglycemia. So one of the important key attributes of Novomix 30 is that with one pen, you can address both the fasting and the postprandial blood glucose. There's a flexibility with regards to administration, as Novomix 30, which is a premixed insulin analog, can be given once a day, twice, and also 3 times daily. So and it's easy to administer because it comes with pen, and there's a lower risk of hypoglycemia because it doesn't have that shoulder effect that premixed human insulin has. So how do we initiate Novomix 30 in patients who require insulin therapy? So it's quite simple. Novomix 30 can be initiated at once a day medication, and the dose is usually 12. You start with 12 units before dinner if you want to give it at once a day. For those who you want to initiate insulin twice a day, you give it as 6 units with breakfast, 6 units with dinner. So it's quite easy to administer. You don't need to do much juggling with regards to the weight of patients. So Novomix 30, initiation dose once a day, 12 units before dinner. For people who want to initiate twice daily, 6 units before dinner, before breakfast, and 6 units before dinner. And you titrate in that light. So Novomix 30 comes in pen, easy to administer, about 300 units, the same storage between 2 to 8 degrees Celsius before use. Once in use, it can be stored at room temperature. And also remember that because it comes in pen, patient can move around with it, just put it in their pocket on a small device and can take that alongside with them wherever they go to. So while trying to round off, I will quickly discuss a case scenario of how to initiate patient on Novomix 30. So we had this 45-year-old male civil servant I saw in the clinic, body mass 31 kg per meter square, weight is 87 kg, blood pressure 130/90. When he presented, the average fasting blood glucose was 8.4 millimoles, postprandial 30, and HbA1c was 9.2%. Patient was on metformin 1000 BD and glibenclamide 10 milligram BD. This is quite a very high dose. For his antihypertensive, he was on perindopril and rosuvastatin. So control was poor, so we agreed that we're going to initiate Novomix 30 at 6 units pre-breakfast, 6 units pre-dinner. We discontinued the glibenclamide and continued metformin. And we agreed on the glycemic target, which is 4 to 6 for the fasting and 4 to 9 for the postprandial blood glucose. 6 months down the line, the average fasting blood glucose is 5.8 millimoles per liter, and the mean postprandial blood glucose was 8.2. HbA1c had dropped to 7.4%. Of course, we continued the antihypertensive, and then we educated the person on medical nutrition therapy, regular exercises, and also encouraged him on weight loss. Of course, we didn't forget to educate on management of hypoglycemia. I know hypoglycemia is a concern most clinicians have, with regards to management of type 2 diabetes. But once insulin is initiated in the appropriate dose and patient educated on how to titrate, hypoglycemia would oftentimes not necessarily occur. So in summary, insulin is an important and integral part of management of type 2 diabetes patients, and it should be initiated when the glycemic targets are not being met. And this includes fasting plasma glucose, 2 hours postprandial, as well as the glycated hemoglobin. And the premixed insulin, either Mixtard, which is a premixed human insulin, or the premixed insulin analog, such as Novomix 30, are good options. Actually a fantastic option for initiation of patients with type 2 diabetes in order to achieve good glycemic target. Thank you very much.
Thank you very much, Novo Nordisk. That was a good one. We gave you all your time, not asking for extra time. So now I want to invite New Heights trainer, 15 minutes. They fast with our New Heights. Odunayo Oladoye. New Heights farmer, you are not here. You are not ready. Okay. Headline. Headline, come for the fast. Headline. Hurry up. The pre-launch talk. Just give you 10 minutes. Headline. Move it, move it. 10 minutes. Want to go for lunch?
The chairman of the occasion, all delegates, doctors, and your spouses, you're all welcome. My name is Emmanuel Atokolo. I'm representing Healthline Limited. And I'm here together with manager, Mr. Jerry and Ms. Joy Ibeto. So today we'll be discussing Bifasa, but first, just a brief about Healthline Limited. Healthline Limited in 2008 by the late Mr. Ram Abuja and from Amara Chikwendu. Commercial operations in the company started in 2012 with medical tourism business, where over 500 patients were treated successfully at a partner hospital in India. Pharmaceutical importation and distribution started in 2013, and in 2015, South Africa joined the company as a strategic investor. Our current business partners are Mylan Laboratories, India, M Pharmaceuticals, India, Workout Limited, India, Swiss Ghana, ICPA Health Products, India, ACM Laboratories, France, and Botu, Morocco. The key therapy segments are ARVs, antihypertensives, antihepatitis, dermatology, anti-infectives, oral care, diabetes, anti-anemics, NSAIDs, antihistamines, antimalarials, expectorants, antacids, immunosuppressants, antispasmodic, anti-ulcers, corticosteroids, and medical devices. Product portfolio, we have about 10 to 15 brands sold in each of the focus markets, and our key markets are in East Africa, South Nigeria, East Nigeria, South Nigeria, West Nigeria, and in Northern Nigeria. So a brief about cough, because what we'll be talking about today is our cough expectorant, Bifasa. In respiratory disorders, it is noted that cough is a common representing symptom causing distress. And types of cough include the dry, trickly, non-productive cough, persistent constant tickle, hacking. We also have sensitive throats, no mucus expelled. We also have wet, chesty productive cough, up mucus, wheezing, chest tightness, difficulty breathing, like in mild asthma, cough associated with dry cough, non-specific. Introducing cough syrup for all. The presentation. Biphasor. It's an effective and complete cough syrup for all types of cough types with salbutamol 1 milligram, guaifenesin 50 milligrams, bromhexin 2 milligrams, and menthol present. The syrup is golden yellow in color, offers a palatable raspberry taste, and is recommended across all age groups except children below 2 years of age. The composition. Each 5 ml of Biphasor syrup contains salbutamol sulfate IP, equivalent to salbutamol 1 milligram, bromhexin hydrochloride IP 2 milligrams, guaifenesin 50 milligrams. The complete cough syrup with great taste, with raspberry flavor. Salbutamol is an effective bronchodilator, a direct acting sympathomimetic agent which demonstrates relatively selective action on beta-2 adrenal receptors. We also have guaifenesin, an expectorant, increases respiratory tract fluid secretions and helps to loosen phlegm and bronchial secretions. We also have bromhexin, it's a mucolytic agent, increases sputum volume and reduces the viscosity of bronchial secretions in chronic bronchitis patients. The features and benefits of Biphasor. It covers all types of cough. It gives liberty to the prescriber to recommend without considering what kind of cough. It has an effective bronchodilator, which makes breathing easier. It contains mucolytic agents to loosen the mucus, helps to clear the airways with minimal effort and coughing. It has expectorant action, makes it easier to expel mucus with little effort. It makes coughing adequate. It also has menthol, provides quick soothing relief. And it also has a pleasant taste, encourages compliance in patients. Pharmacokinetics. This is just talking about the pharmacokinetics of salbutamol, guaifenesin, bromhexin. It's indicated in all types of cough and in asthmatic cough, especially. The dosage in adults is 10 ml to be taken twice daily. Orally, children 6 to 12 years is 5 to 10 ml to be taken thrice daily. Children 2 to 6 years, 5 ml to be taken thrice daily. Syrup is not recommended for children below 2 years of age. Warnings and precautions. Cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension, convulsive disorders, diabetes mellitus, glaucoma, hypokalemia, sensitivity to symptomatic amines. Guaifenesin may increase mucus secretion with cough. Also, bromhexin may aggravate gastric ulcer. This is a study was undertaken to compare safety and efficacy of 2 cough formulas, a combination of beta-2 agonists, bromhexin and guaifenesin, and other cough formula, the control, in the management of cough associated with respiratory disorders. The findings of this study suggest that cough formula containing combination of beta-2 agonists, bromhexin and guaifenesin has better efficacy as well as better patient acceptability. Efficacy of salbutamol. Okay, let's do the comparative efficacy of salbutamol. One study compared the acute and chronic effects of salbutamol syrup and metaproterenol syrup, 10 milligrams, 3 times daily for over 28 days in 65 children aged 6 to 9 years. Okay. With mild to moderate asthma. These findings imply therapeutic advantages of salbutamol syrup over metaproterenol syrup is currently recommended doses with respect to improvement in pulmonary function and frequency of dosing required to maintain optimum bronchodilation over a 24-hour period. So this is a promo we are currently running. If you visit our stand, Healthline Limited, you buy 4, you get 1 free. Please visit our stands. We have a lot of gifts, promo items, Healthline Limited. We also take the opportunity to introduce our other products, Orofa, a safe and reliable iron source, good tolerability. Orofa is also available in our stands. We also have Infane, a double-barrel attack on pain with unique and central peripheral actions compared to other NSAIDs. Discard allergy for seasonal and perennial rhinitis. Utilef. So please visit our stands. We have a lot of promo. You can win generators, television, and this microwave. If you buy Infane, okay.
Thank you very much. New Height, please come. We don't allow speakers for one product, please, for now, for today. New Height, come up, please. Thank you very much. We are coming to your stand. We'll come to your stand. We'll patronize you. Thanks a lot. A round of applause for them, please. New Height.
I'm still standing on the existing product. It's my
New Height Pharmaceutical, vitamin D3.
Okay. I'm here to present NHP, vitamin D, and health. NHP simply means New Height Pharmaceutical. And we can see, I am not going to be dwelling more on definitions of vitamins. As we all know, as a physician, we are familiar with this. Vitamin D is a source. It has 2 sources. We have the cholesterol and directly from the sunlight. And we can see that the active form of vitamin D3 is 125-hydroxyl vitamin D. That is the active form of it. And we can see the benefit of vitamin D3. It helps in teeth formation. It helps in calcium absorption, bone formation, muscle, and cell division. We can see other benefits of vitamin D3. We can see some are used in pregnant women. Research has shown that 80 to 1
per day. It helps the immune system during cold and flu. Also, as you can see here, the question deficiency possible can occur. And to sunlight.
We talked about sunlight. The question is, how often do we expose ourselves to sunlight? And we can see some factors that are associated to it. For us to get sunlight, you can see a lot of them. I will be mentioning them because of my time. It is due to season, time, date, length, smog, age, and sun exposure. Research has shown, this research was carried out in Kano, that is the epidemiology of vitamin D, and it was shown that vitamin D, we can see deficiency of vitamin D in women, especially the Fulani part of the northern region. Symptoms of vitamin D deficiency. Most patients with vitamin D deficiency, they can have what we call hypoglycemia, hyperparathyroidism, and also osteoporosis, as I've said earlier on. Patients with a prolonged and severe vitamin D can experience symptoms associated to hypothyroidism, including bone pain. We can see symptoms of the deficiency. It can affect the brain, the respiratory system, the circulatory system, the pancreas, the muscle, and the bones. Treatment or the management of this vitamin D3. The management of this, we can supplement like NHP, vitamin D3 can be used to treat or to manage deficiency of vitamin D3. We can see here is the NHP vitamin D3. It has two strengths, 50,000 IU and 10,000 IU. The question is, why NHP vitamin D3, 50,000 IU and 10,000 IU? We can see the uniqueness of this vitamin D3, they are as follows. The dosing frequency, which helps in advance due to 1 tablet per day. People that are scared of taking drugs all the time, you can recommend it for them. For the 10,000 IU, they can take 1 per day. For the 50,000 IU, 2 in 2 weeks, once in 2 weeks. Also, it has economic value compared to lower strength. Adherence any time of the day or any time of the week. You don't need to bother yourself. If I miss my medication today, what will I do? The question is, the 10,000 IU can cover you for the whole week. It is being manufactured in a standard company in the UK, distributed by New Height Pharmaceutical. New Height Pharmaceutical is also a franchise owner of Omron here in Nigeria and Africa as a continent. It comes with barcode braille, which enhance or helps to secure the authenticity of this product. It is easy to swallow compared to other that are bigger. We can see some other important products of New Height Pharmaceutical. We have our vitamin C. It is time-released vitamin C with high strength. It contains citrus bioflavonoids. The benefit of this on our skin, we can see it may help to protect against sun damage, serves as an antioxidant, in vitamin C. It may also help to defend against damage due to ultraviolet light. It might also help to lighten dark spots. It helps in smooth wrinkles. So we can, apart from that vitamin C, we have some other important products such as paracetamol suppository, 125 milligram, and we have the one and only ibuprofen dispersible in town, 200 milligram, and we have our ibuprofen suspension. All of these are management, they can use to manage pain across all ages. Also, we have our brain enhancement across all ages, like our FMO. We have ranges of FMO. We have FMO brain liquid. We have FMO brain formula, and we have FMO active memory for elderly people. All of this helps in enhancing the brain function. And also we have our evening primrose. The evening primrose also helps in hormonal imbalance. I want to say a big thank you for the privilege.
You really kept to time, 9 to 10 minutes. Thank you very much. So Emzo, hurry up. Emzo Pharmaceutical, Ndubuka, Emmanuel. Emzo, you should have done that since. We don't have that time to waste. Please hurry up. 10 minutes, no, let him come.
Yeah, what you're looking at right now is our ultra-modern factory in Shagamu, built to WHO capacity. So we're proud to be an indigenous pharmaceutical company in Nigeria that will deliver to you most of the imported products that you're used to knowing. Now they are going to be produced in Nigeria. WHO standard beta-lactam factory from Emzo Pharmaceuticals. That is who we are. Can I get assistance, please? Okay, so what you have just seen right there is, sorry, can I go to next slide? Thank you. What you have just seen right there is our factory in Shagamu. Next slide, please. The main presentation slide. There's a presentation slide after this video. Thank you. All right, so you have just seen our WHO standard factory in Shagamu. Emzo has acquired a large expanse of land in Ogun State, Shagamu. So there, we're going to be coming out with a lot of products. Products ordinarily they are not manufactured here in Nigeria because we don't have that facility. You know, the beta-lactam, you know, products. Please, can I get your attention? The next slide, please. Okay. Okay, thank you very much. So that's who we are. We are Emzo Pharmaceuticals. And I bring you greetings from our MD CEO, Dr. Stella Okoli. This is a woman that that's championed, you know, all of what we're going to be saying today. She's a woman that has energy and passion and has demonstrated that in several ways. So it is in this light that would go into the presentation and what Emzo has to offer. We are your ideal partners in the delivery of unlimited wellness to all. Emzo is your ideal partner in delivery of unlimited wellness to all. Talking about our vision, we have the Faculty of Sight. Sorry, I'm having challenges with it. Beg your pardon. Okay. Okay, going back. All right, thank you. All right, thank you. So we'll have the Faculty of Sight to be leading pharmaceutical pharmaceutical industry in Nigeria. So that is our vision. And what as much as possible to achieve that. Our mission is to have an unwavering commitment to providing customers with healthcare products and services of consistently high quality made available at prices that create value for all stakeholders. And because basically of the challenges in the country at the moment, we know that Nigeria is not immune to malaria. And so in that light, we stepped in, you know, to providing us with anti-malaria products, which we have, you know, a number of them from the Lockmal QS to Maldox, Piramal, and so many of them that we're also coming up with in the future. So Emzo played a leading role in the eradication of polio in Nigeria. That's one of our legacies. Zolon, HESCO, Vaccine are all subsidiaries of Emzo, and we played major leading role in the eradication of polio in Nigeria. We have over 140 NAFDAC approved products. Just to mention 140 coming in. So in terms of globalization, we all know about the African Continental Free Trade. Ready to step into that space at the moment. We love the words of Ralph Waldo Emerson that says, what lies in front of you and what lies behind you are tiny matters compared to what lies within you. So it is in this light that Emzo is looking within to say, how can we locally manufacture what we need in this country? How can we be indeed the leading pharmaceutical manufacturer in Nigeria? You see, we have stepped in to bring in a couple of products. And so these challenges that we have in the country has built, or the challenges have built our values. We are committed, we have passion, energy, and we are ready to exhibit excellence in all that we do. Now, our journey spans through 1977, when we started as Emzo Chemist. In 1977, it was just a little chemist somewhere in Lagos State. And over time, in 1984, we came out with our first product, paracetamol, when we started manufacturing. And through 1988, 1993 to 1999, we currently have 3 factories, functional factories in Lagos State. And in 2001, thank you very much. Thank you very much. In 2001, we have a mega factory as I speak to you right now, and that's the factory you just saw. You know, a mega factory in Shagamu that is capable, you know, of meeting the needs of our needs as pharmaceutical industries. So in 2001, as I talk to you at the moment, we have a standard beta-lactam factory in Shagamu, and we're coming out with a number of products that used to be imported. Of course, the COVID era had made us see the need to locally manufacture, and it is also time for us to begin to patronize local content. You know, because during this COVID era, products became scarce, APIs were difficult to import and all whatnot. You know, shipment was a problem and what have you. But with Emzo Pharmaceuticals currently in Nigeria, we are able and we will be able to overcome further challenges if it occurs again in the future as regards manufacturing of pharmaceutical products. These are therapeutic segments, a couple of them. just to mention a few, from analgesics to antibiotics, gastrointestinal, cardiovascular, anti-malaria, antifungal, the topicals, nutritional oils. You've heard about evening primrose, omega-3, vitamin E from Emzo Pharmaceuticals. So these are therapeutic segments, cutting across this therapeutic segment. And we are also getting into locally manufactured beta-lactam in our Shagamu factories. Now, of these, I'll just point out a few of them. We have a couple of NSAIDs. The celecoxib, is worthy of note. So Emzo has come up with a couple of NSAIDs, celecoxib. We have diclofenac potassium, piroxicam. So these are a couple of them that we have come up with and are going to be locally manufactured here. Okay, and then we also have antihypertensives. They are manufactured, they used to be imported before now, but right now they are going to be manufactured here in Nigeria. Lisinopril, we call it Emzipril, and Emzovasc. Okay, so I won't spend time telling us about celecoxib, but I would point out very clearly that our Emzobrex, our brand of celecoxib, is one product that can guarantee you efficacy. We benchmark, the leading and high quality molecules there are in the country, and we benchmark that and we're giving them to you at prices that are affordable. Now, I'll round off with these few slides to tell you that we are not just alone as Emzo Pharmaceuticals. We are your one-stop medical solution provider. We have other subsidiaries. We have Zulon Healthcare. We have Zulon Healthcare. We have the Emzo vaccine, and we have the Emzo Hesco. Okay, so from paracetamol that most people know Emzo to be, we have developed into other subsidiaries, or we have developed other subsidiaries. Zulon Healthcare on Friday, Zulon will do more talk and tell us more about that. Vaccine, we are also into vaccines, and then Zulon Emzo Hesco is one of our subsidiaries that is into medical equipment and diagnostic. Is a diagnostic